Welcome back to the Derm Club podcast. Patients with psychocutaneous disease may present to multiple professionals to seek care, but the challenge is that a dermatologist may be unfamiliar and uncomfortable with assessing psychosocial information, and a psychiatrist may not even know management protocols for skin-related conditions. An interdisciplinary approach is required in these circumstances to take care of the patient or these patients. To better understand the correlation between dermatology and psychiatry, as well as explore some of the common medical conditions where the two intertwine, we have the pleasure of having Dr. Ladan Mostaghimi on the Derm Club podcast today. Dr. Mostaghimi is well known nationally and internationally as a lecturer on psychocutaneous medical disease. She is certified by the American Board of Psychiatry and Neurology, in addition to residency training in dermatology from France. Currently, she serves as the director of a private clinic called the Wisconsin Psychocutaneous Clinic, with the core mission of educating and training dermatologists and psychiatrists that are interested in further education on psychocutaneous medicine. She is also the former chair of the University of Wisconsin-Madison Psychocutaneous Clinic that she led for over 16 years. She is also the current president for the APMNA, the Association for Psychoneurocutaneous Medicine of North America. Dr. Mostaghimi, it is a real pleasure to have you on the podcast today. So welcome.
Hi, very excited to be here and have this chat with you today.
Great. Can you please define for us what psychocutaneous dermatology is? Why is it its own specialty? You know, many of us have either never heard of it or are not familiar with it at all.
So psychodermatology is a subspecialty of psychiatry and dermatology that explores the interactions between the skin and the brain. These interactions are very complex and many times they go through other systems like neuroendocrine and immune system. And what we do in psychodermatology, we consider the patients and the disease in the biopsychosocial model of the disease. So the practitioners need to be knowledgeable in both dermatology and psychiatry, and that's why it's its own subspecialty.
Can you share with us the connection between mind and skin? And does this go back all the way to embryology?
Yes, you're correct. And the close relationship between skin and nervous system and psyche starts with ectodermal origin of the nervous system and a considerable part of the skin. It continues with the skin being the sensory and expressive organ. It's the display of ourselves, and it's a boundary between us and the world. It is the largest organ in the body, and in order to protect us, it contains its own HPA axis and immune and endocrine systems. Skin cells can produce many hormones like CRH, ACTH, and they also have cytokines and neurotropins that are the major stress mediators in our skin. And it's important to know that the connection between mind and skin is a two-way connection. And in order for us to be healthy, they are constantly working together back and forth in harmony.
Very interesting. What is the difference between psychophysiological disorders and primary psychiatric disorders, secondary psychiatric disorders, and cutaneous sensory disorders? Because I understand that these psychocutaneous disorders are often categorized into these four categories.
So actually there's 5 of them, which Dr. Koo started to introduce this classification of psychocutaneous diseases as in 5 categories. One of them is psychophysiologic disorders. Those are skin problems that are triggered or are made worse by stress, like psoriasis, atopic dermatitis, acne, seborrheic dermatitis. Then you have the primary psychiatric disorders, when patients come to you with a skin lesion, but the primary problem is psychiatric disorders and there is no real skin disease, if you want, like trichotillomania or delusions of parasitosis. And then you have cutaneous sensory disorders that are equivalent, if you want, of chronic pain syndromes. It's when patients have these unusual, annoying sensations of burning, biting, itching, for which we can't find any skin diseases, and we may or may not be able to find a psychiatric problem in those patients.
So, a lot of this seems to be induced by stress, which we often hear stress can induce many things, hair loss, many other health conditions. What is the effect of stress on the body and the skin? And can you relate that to the relationship between psychodermatology and epigenetics?
So as you know, epigenetics regulate the genomic transcription. And research in the last decade has shown that many patterns of epigenetics are altered in response to environmental factors like social or physical insults and injuries. And sometimes they can cause changes in genes that are gene functions that may be permanent, and sometimes we may even pass it to our offsprings. They have shown epigenetic changes happens in mothers that are smokers, and it can cause the offsprings to have more atopic dermatitis. And exposure to anxiety, depression, or stress during the pregnancy causes a surge in cortisol level in moms. And it's a lipophilic molecule, so it can pass through placenta, even though placenta has an enzyme that will convert it to a deactivated form. But regardless, when there is too much cortisol in mom's body, you have dysregulation of HPA axis in their offspring. So the mothers that have been under stress, there is a shift in immune response from T helper 1s to T helper 2 in their child, and they can get more asthma or atopic dermatitis.
Fascinating. How often do you see that correlation where there's this off balance axis and then they develop either asthma, atopic dermatitis, or other dermatologic conditions as a result of it?
So it's really hard to pinpoint the cause and effect, but atopic dermatitis is one of the most common skin diseases affecting 10 to 25% of children in industrialized countries and 7 to 10% of the adults. And the vast majority of these patients have high IgE in their body, and they're sensitized to multiple environmental antigens, and they have trouble with their microbiota, their skin microbiota, and many of the symptoms are because of the dysfunctional of their epidermal barrier and the water loss and dry skin that opens the skin up to more injury. And as I said, they have more of a T helper 2 type response, and that can be affected by maternal stress.
Is there anything we know? Oh, sorry, yes.
And if your HPA axis is activated, you have too much cortisol. We know that cortisol can shift your response towards a T helper 2 response.
So at this point, is there anything we know we can do prophylactically or recommend to the mother, either before she tries to get pregnant or while she's pregnant, so that she can have her HPA axis in a better balance and her cortisol levels in better balance, so that it's less likely to affect her offspring?
So the interesting thing with the stress and the stress response is that not everybody has the same response to the same triggers. And what's important is for you to know what's your stress tolerance and what things stress you out, and try to decrease them the best you can. We don't want you to feel guilty about not feeling stressed at all, because that kind of triggers the guilt feeling more of the stress. But you can do things like yoga, Tai Chi, meditation, or other things that help you tolerate the stress better and cut down on the environmental stressors like smoking, drinking, and other things that can have negative effect on pregnancy.
Do you recommend yoga and meditation to all mothers?
I think it'd be a good idea if everybody start to do some of those practices. There
It
was
sounds
a
like it.
study that showed that there was like even the telomeres in women increase in size with the meditation. So it can have like really nice health effects. And I believe Dr. Kabat-Zinn has shown that in psoriasis, mindfulness meditation together with UV treatment, people who had the meditation cleared their skin much faster.
Wow, the relationship is so fascinating. So, of course, you have a lot of experience. Do you find it difficult to recommend a psychiatrist to a patient or even a therapist to a patient who you've seen in the dermatology clinic, whose condition you know would improve from it, and it's not improving alone from just seeing a dermatologist?
So it all depends on the rapport you have with the patient and how much they trust you. It's very difficult to tell them from the beginning that, oh, you need to see a psychiatrist, you don't need to see me. Because if a patient comes to dermatologist, they want to see a dermatologist. And they knew if they wanted to see a psychiatrist to call another clinic. But once you show concern and compassion towards their suffering, you have a good rapport with them, then you can educate them on how you believe that seeing a psychiatrist can help improve their symptoms. You can also do some screenings for mental health issues, and that will open a door for the conversation between you and the patient.
Yeah, and I think now there's like a much bigger push and understanding and acceptance of seeing a psychiatrist or a therapist, mental health issues, it used to carry such a negative connotation to it. And I think that over the last few years, especially after the pandemic, we've really seen like a much more of a open discussion about mental health issues. So hopefully that only continues to improve patient outcomes and this specialty.
Yes, one important thing is that now, like most of the internal medicine areas, they have started to integrate internal medicine with mental health services. And I'm hoping that the specialties will go the same route and will integrate mental health in their services.
Collaborative care.
Yes.
So how do you categorize these psychodermatological disorders, and can you break them down for us?
So that we talked already about Dr. Ku's classification of the 5, and we've talked about 3 of them: the psychophysiologic disorders, the primary psychiatric disorder, and the cutaneous sensory disorders. The other 2 are secondary psychiatric disorders. This is when you have a disfiguring skin disease, and because of the stigma, you start to feel depressed or anxious about it. And then the last one is the use of psychotropic medications for non-psychiatric purposes. Like a good example is use of some of the antidepressants, such as doxepin or mirtazapine, for patients that have itching. It can help the itch and can help their sleep. So alternatively, what we have been working on at APMNA and also the European Academy of Dermatology and Psychiatry, we have been interested in finding classifications that can help to streamline the research and the conversation between the 2 specialties. And I feel it's really important that we integrate the DSM-5 diagnosis into dermatology. So it's interesting for me to know that in psychiatry, DSM-5, we have excoriation or a skin picking disorder. And this has more than 10 names in dermatology literature. They call it dermatotillomania, psychogenic excoriation, compulsive skin picking, pathological skin picking, dermatitis, para-artefacta, and about 8 other names. So it's really hard to do research, especially retrospective research, and you have to combine all these searches and all that. So it'd be to the benefit of everyone if we just call it excoriation disorder, and that way we can have a common language. So in last year, or actually in June of 2020, issue of International Journal of Dermatology in collaboration with Dr. Jafrani and Dr. Tusk, I published an article with DSM-5 psychiatry equivalents of psychocutaneous disorders, and it has a nice table, and we're hoping that people will start to use that table and use the same names.
Very helpful to know about that. So how do you approach a patient who feels like their identity and their self-esteem or self-worth is their skin issue? Like I've met patients who they feel like the first thing, they have really bad acne, and they feel like the first thing anyone sees before they see it, like, what's your name? They see their acne. And it has gotten them to the point of being suicidal. So how do you approach a patient in that situation?
So first thing first, suicide is a psychiatric emergency. So if a patient talks to you about suicide, you have to take them seriously. And we need to do a complete suicide risk assessment for them. Like we can use Columbia Suicide Severity Rating Scale. And based on their response, we may even have to do a more comprehensive evaluation and have safety planning for them. However, if you see that the patient just has suicidal ideation, but they're not in no acute risk, you can have a safety plan for them. And it's really important to see them more often. What we need to do is to screen them to see if they have depression and anxiety and propose the right treatments for them. It's also important to work on their self-esteem and self-worth and help them focus on their other talents and abilities rather than just the skin disease, so they don't identify with the disease and they know that like they have a bigger persona and a bigger life than just their skin disease. That can be helpful, especially in children and adolescents, to focus on their abilities and talents can be very helpful.
Okay. And so I was doing research and I came across articles by Dr. Gupta and Dr. Men Chung, and it was specifically about chronic idiopathic urticaria and its association with PTSD. And as I know, and as you know, and many other dermatologists know, itchy skin can really be quite frustrating and debilitating to the patient and difficult to treat because it's hard sometimes to find the underlying cause of what is making the patient's skin itch. So how do you go about that?
So I think Dr. Chang has his research has shown that the prevalence of CIU or chronic idiopathic urticaria is about 32 to 34% in patients with PTSD. And Dr. Gupta is one of the first one that noted that possible co-occurrence of PTSD and chronic urticaria. So one of the main features of PTSD is a hyperactivity of their autonomic nervous system and hyperarousal that the patients are experiencing. And when you have that hyperarousal, you have more adrenaline and norepinephrine in your system, and that can be a triggering factor for hives or make them worse and all that. So it's mostly the PTSD being a chronic mental health issue causes a lot of alterations in HPA axis and in SAM or sympathetic adrenal medullary system axis. And through that, it may affect the itching and causes inflammation in patients' skin.
I had a patient who had terrible prurigo nodularis and he was extremely itchy, but he did say that when he went to work, he was distracted and he forgot about his itchiness. When he came home and he was sitting on the couch after work, that's when he really started to itch and he got excoriations and it really just got bad. And so we referred him to therapy and a psychiatrist, and it seemed like that was the best way to manage his itch more than any other medication or drug that we could possibly find. Is that your experience as well?
Yes, usually like when the itch is that severe, it's really important to take care of the psychological issues that comes with the itch, and usually that helps to decrease or attenuate the itch, and eventually it will go away once the psychological issues are resolved, as long as it is a psychological itch.
How do you differentiate between psychosomatic and not? There's a very fine line between something being a symptom being psychosomatic and physiological. For instance, like if I have an itch on my skin, how do I know, is this psychosomatic or is this a physiological itch? What kind of emotions do you look for in a person to help you determine this?
So usually, like for me, the psychosomatic is a diagnosis of exclusion. I usually do a complete skin exam and blood checks and all that, because itch is multifactorial. There are many things that can cause itching. There's inflammatory skin problems, atopic patients, and patients with hives. You can also have general medical problems like iron deficiency, kidney problems, liver problems. Some medications can cause itch. So I look into all that, and if I can't find any other causes, then I do a screening for mental health issues. And anxiety is a big provoker of the sensation of itch. And we know, like the same way that with pain, if you have depression or anxiety, it decreases your threshold of pain tolerance. The same thing happens with itch. If you have depression and anxiety, you have less tolerance. And you scratch, and the more you scratch, it becomes a vicious cycle, the more you itch.
Yeah. What is the best plan of approach involving treatment modalities? I know you suggested meditation, yoga. What other options are there? And what screening tools do you use and when you're speaking to a patient?
So in regards to screening, I usually do screen patients with depression and anxiety. I usually use the patient health questionnaire, or PHQ-9, for the depression. And that's a good one. The question number 9 is actually about suicidality. So if somebody answer is positive on number 9, then you know that you have to do more investigation into that. I also use the GAD-7, which is generalized anxiety disorder. Then depends if I am suspecting OCD, Yale-Brown obsessive compulsive scale, or YBAC is a good one. We have dermatology, quality of life questionnaires. I also usually screen patients for sleep problems and fatigue, because these are the things that also can affect the quality of life, and some inflammatory skin diseases can affect the sleep. And what treatments that we use, like if a patient has trouble with compliance and adherence to medications, we do use motivational interviewing. But I've used all different styles of therapy. We have used cognitive behavioral therapy, behavioral modification for people who are skin pickers, mindfulness. The patient sometimes need family therapy, couple therapy. So it's tailored to the patient, depends on their problems.
Yeah, every patient story is unique. What different types of psychocutaneous clinics exist?
So right now there are 3 different types that I'm aware of. One is that the dermatologists and psychiatrists or psychologists are working in the same clinic and seeing patients together. The problem with this is the productivity, because as you know, the dermatologist has much smaller time frame with the patients than psychiatrists or psychologists. So this model may work good in a single payer system. The second one is a dually trained psychiatrist, dermatologist, physician has a tertiary care psychocutaneous clinic and sees the patients by referral. That's the clinic I had for UW. And the last one is that a dermatologist sees the patients and then tries to refer them to psychiatrists or psychologists that are trained in psychocutaneous medicine. But as I said, unless you have a good rapport with patient and educate them why they need to see a psychiatrist or psychologist, it may get them upset.
Yeah, I know, I'm aware. So what is your advice to other dermatologists who don't have a psychodermatologist in their practice? You know, that's not a very common thing that I've seen in the past.
Okay, yeah, I believe since our resources are limited, the best approach that I'm pushing for is to train the dermatologists so they're able to see the patients, screen them for any mental health issues, maybe start the treatment, have a good rapport with the patient, and then do the referral for more complicated cases. And once the patient is trusting them. So our association APMNA website has the list of all the experts, and it's a good resource. We usually have our meetings once a year, the day before the American Academy of Dermatology meeting. This year, we are meeting in Boston on March 24th.
Yeah, so it sounds like, you know, to build a good rapport with a patient, it could take time. So until you really can like get to the bottom of a patient situation and get them to a place that's better, it's not going to be something that happens right away.
Yes, and one important question is to ask the patients how the disease is affecting them, how it's affecting their relationships with others, and do they feel they're at their max productivity, or is the disease and the treatment is too time consuming and all that. Many times we get upset that the patient didn't listen to me, they didn't use it, but in dermatology, we have treatments that are really time consuming to use. And many of us don't have that much time in our day, in our busy day. So to be understanding and be compassionate, it goes a long way.
Definitely. You know, like I was talking to someone else and they were saying that adherence with using topical ointments is much lower than the adherence of just taking a pill. But it's that compliance, maybe the use of telemedicine to check in more frequently on a patient can be something that helps us in the future, or digital health tools. Where do you hope to see the subspecialty of psychodermatology go in the future?
So I have been looking into different ways on how we can advance this cause and help the patients better. And I feel that we must have a multi-level approach to the problem. So we do have societies like APMNA, like European Academy of Dermatology and Psychiatry, European Academy of Dermatology and Venerology. They have a psychodermatology task force. So these are the societies that are actively looking into how to spread the word and how to find better solutions for the patients. But this by itself may not be enough. So we do need academic institutions to increase the teaching for the residents and the dermatologists. And maybe increasing the number of board exam questions will encourage the young dermatologists to learn more about psychodermatology problems. We also need to identify sources to increase the research funding for psychodermatology. It's kind of in a no man's land between psychiatry and dermatology, and it's hard to find good resources. And then we do need to have an increase in publication in high impact dermatology journals. When I am looking in finding cutaneous articles, they're all over the place. And like, this is one of my projects. I'm looking into the psychocutaneous publications between 2011 and 2021, and all journals and the highest impact dermatology journals. And a journal like the Journal of Investigative Dermatology has only one article in 10 years. So we do need to add to the number of publications and find ways to improve the connection and working between psychiatrists and dermatologists. So, and for my part, like that 16 years that I had the clinic for UW, I analyzed all the data, and I wrote an article in the Journal of the American Academy of Consult Liaison Psychiatry in May of 2021. And I summarized like the clinic operation, what sort of patients we saw, what treatments we offered. I think having more of this type of articles can help people have an idea of, okay, what it takes to have a psychocutaneous clinic for them.
Sounds like we need to really push more for awareness and just to get the message out there. So, I feel like maybe even starting in medical school is where during their dermatology module, is where we can start making students and future doctors aware of this specialty so that they can make an impact on it.
Yes, I think like we also need some anti-bias training in medical schools and other places, because there is still a lot of bias against mental illness, not only in our patients, but also in our doctors. Like there was an old article in Germany, medical students, they checked them and they all had bias against psychiatry and psychiatry rotation. So educating early and often is the answer. And that's how I realized that there's so much interactions, and I got interested in doing psychiatry. And that's when I came here and I had to redo a residency, I decided to go for psychiatry. It's fascinating, like to know how the brain works and how it affects our whole body.
Yeah, who would have thought that it had an impact on our skin? So Dr. Mostaghimi, thank you so much for joining me today. It was a really interesting conversation, and I hope to speak again in the future.
It's my pleasure. Thank you for having me.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.